Let us discuss about selection of antibiotics in emergency room. When we have a patient who is having suspected infection, we can do following investigations. Complete blood count. If the patient is having bacterial infection, WBC counts are normally elevated. In viral infection, they are normal. But infections like enteric fever or leptospirosis, the counts can be still normal. Next investigation is urine routine. If the patient is having fever, chills, rigors, urine routine will be very helpful to diagnose urinary tract infection. And once we see pus cells in the urine, we have to send for culture. Culture may take 48 hours. Before that, we can start empirical therapy. Chest X-rays are very important in respiratory tract infections like pneumonia, LRTI, aspiration pneumonia and all. So that should be taken. Pus culture and gram stain is very important if there is a skin infection. Gram stain is one investigation which we can get very fast. So depending on the gram stain, we can initiate empirical antibiotic in skin infection, especially ulcers. Next important investigation which can be done in an infection is procalcitonin. We know that procalcitonin is one investigation which will be elevated in bacterial infection. If we have doubt regarding the etiology of the infection, like whether it is bacterial infection, viral infection or fungal infection, we can send procalcitonin. If procalcitonin is elevated, it is mostly a bacterial infection. If it is highly elevated, it can be sepsis also. Now we'll discuss about selection of antibiotics in lung infections. If the patient is fully stable and if the patient is ready for discharge, if the patient is having a lung infection like LRTI, azithromycin will be a very good choice because most of the patients who is having community acquired infections in the lung can be gram-positive organism. Azithromycin is a good choice. 500 mg once daily, 3 to 5 days is enough in this type of patients. But if the patient is having coexisting diseases like chronic diabetes, heart diseases or previous lung diseases like COPD or ILD, there is a chance of gram-negative organism in the lungs which can produce infections. So we have to go for little higher antibiotics like respiratory quinolones. Moxifloxacin is ideal choice here, 400 mg OD or levofloxacin 750 mg once daily for 5 to 7 days. Moxifloxacin and levofloxacin are respiratory quinolones, whereas ciprofloxacin, ofloxacin, norfloxacin they are also quinolones, but they act below diaphragm, like they are drug of choice in infection below diaphragm. Above diaphragm, better select moxifloxacin or levofloxacin. Alternatives are amoxicillin clavulanic acid, that is augmentin, 625 mg TID, 5 to 7 days can be given. Some physicians add azithromycin also because it may cover atypical organism. Now, if the patient require ICU admissions, inpatient, non-ICU and ICU admission, like if the patient require admission and if the patient is going to ward with a respiratory infection, levofloxacin will be an ideal choice. 750 mg IV OD is an ideal choice. But remember, in elderly individuals, quinolones can produce seizure in some patients. If there is a seizure potential, like patient is having previous history of epilepsy, better not try this drug. We can go for alternative therapy like ampicillin sulbactam or ceftriaxone or azithromycin with ertapenem. Like that we can select alternative therapies. But in patients who have a respiratory infection who are getting admitted in ward, moxifloxacin or levofloxacin IV will be good choice. If the patient is getting admitted to ICU, we need to give higher antibiotics like ceftriaxone. It's a third generation cephalosporin. You can give 2 gram IV OD, start from ER and can be continued in ICU. Alternative drugs are ampicillin sulbactam, Again, moxifloxacin, levofloxacin, IV can also be given. If the patient is having severe infection, meropenem may be required. 1 gram TID is a dose. But routine infections, meropenem is not a good choice because it's a higher antibiotic. It has to be preserved. So we should not use unnecessarily meropenem. We can go for levofloxacin or moxifloxacin. If you see the coverage of levofloxacin or moxifloxacin, it covers gram positive, it covers gram negative, it mostly covers atypical, it also covers anaerobes. So most of the infection, if the patient is not in sepsis, levofloxacin or moxifloxacin will be adequate. If the patient is in sepsis, we have to go for higher antibiotics like piperacillin tazobactam or meropenem. Now, if we are suspecting pseudomonas infection, like patient is having chronic lung disease or patient is having severe diabetes, uncontrolled diabetes, chronic alcoholism and all, we have to suspect pseudomonas aeruginosa. If we are suspecting pseudomonas, better to go for dual antibiotic coverage, like we can give piperacillin tazobactam with ciprofloxacin or levofloxacin. So always cover 2 drugs for pseudomonas if you are suspecting, or if the culture shows positive result for pseudomonas, we can give piperacillin tazobactam plus ciprofloxacin or levofloxacin that can be continued. If we are suspecting MRSA, like patient is having bilateral pneumonia, a lot of cavitations are there, patient is coming from a different hospital, like admitted in that ICU for many days, or if the patient is on ventilator, we can suspect MRSA also. Or if culture shows MRSA, vancomycin is one good choice, but always remember the patient is having hospital acquired infection, piperacillin tazobactam, ciprofloxacin with vancomycin will be a good choice because we have to cover for both pseudomonas and MRSA. Now, another important condition what we see in emergency room is diarrhea. Most of the diarrheas are non-infectious, like whether the patient has taken some food item which is creating gastritis, or sometimes it can be viral diarrhea, especially in children. They do not require any antibiotics there. So we have to give only supportive therapy in that type of patients. But if the patient is having fever or abdominal pain and diarrhea, there are different classes of drugs. One important drug is rifaximin. It's a non-absorbable antibiotic. It's mainly used in hepatic encephalopathy. It can also be used in travelers diarrhea. 400 milligram, 200 to 400 milligram TID is the dose can be given. In hepatic encephalopathy, slightly higher dose is required, 550 milligram BD is required. But in routine travelers diarrhea, 200 milligram TID is enough. If we are suspecting little higher infection, we can go for ciprofloxacin 500 milligram BD. We are avoiding ciprofloxacin in our country because ciprofloxacin, you know that it's a quinolone which can be used in tuberculosis. So we should try to avoid ciprofloxacin in wherever possible, and because it's a second line drug in tuberculosis. So rifaximin is a very good drug which can be given 200 milligram TID in travelers diarrhea or most of the gastro infections. But most of the physicians they give ciprofloxacin with tinidazole or ciprofloxacin with metronidazole. They are required only in giardiasis or amoebiasis. Most of the infections are bacterial infection. They do not require metronidazole or tinidazole. So we can give ciprofloxacin 500 milligram BD or rifaximin 200 milligram TID. That will be enough. If we are suspecting cholera, if the patient is having profuse diarrhea, rice water stools, then we can go for doxycycline 300 milligram single dose. Probiotics also can be given in patients who is having diarrhea because it helps in the like normal equilibrium of bacterial equilibrium of stomach. So probiotics can be given in patients who is having diarrhea. Now, next common infection in emergency room is infective endocarditis. Patient come with high degree fever, chills, rigors, no focus, cardiac murmurs. We can suspect infective endocarditis. They require echocardiogram to diagnose the lesion in the heart, or sometimes transesophageal echo also may be required. So after taking cultures, multiple cultures from different sites, we can start antibiotics. The most commonly used drugs in suspected infective endocarditis is, this is empirical treatment. This is not treatment after getting the culture. Penicillin IV 2 to 3 million units every fourth hourly, plus gentamicin 1 milligram per kg body weight IV, or ceftriaxone 2 gram per day IV can be given with gentamicin. These are the routine treatment for common infection, that is streptococcal infection. If we are suspecting penicillin resistant streptococci only, we have to add vancomycin 15 mg per kg IV. So routinely used therapy is ceftriaxone with gentamicin or penicillin with gentamicin. We are suspecting enterococci, penicillin plus gentamicin. The same thing which is explained with streptococci. Staphylococci, vancomycin is the choice, because when we are treating staphylococci, it can be methicillin sensitive or methicillin resistant. But before getting culture, we cannot tell whether it is MRSA or MSSA. So in a case like infective endocarditis, where the patient can deteriorate very fast, we use vancomycin. That is a drug of choice. ASEC organisms, if we are suspecting, ceftriaxone 2 gram IV OD is enough. But many physicians, as empirical therapy, they start ceftriaxone, gentamicin plus vancomycin. These are the combinations they use. But if we are suspecting only a community acquired infection, ceftriaxone with gentamicin will be enough. If we are only suspecting a staphylococcal infection like intravenous drug abuses and all, we have to use vancomycin. Now we can see many patients who have chronic liver disease, ascites, come with infections. To prevent infection, that is spontaneous bacterial peritonitis in them, we can use norfloxacin prophylaxis. Norfloxacin can be given for a longer period to prevent infection in ascitic fluid. Or if the patient is admitted in emergency department due to some other reason, to prevent SBP, we can give rifaximin. We have already discussed 550 mg BD. But if the patient is admitted with SBP, high degree fever or abdominal pain, on tapping the ascitic fluid, we get suspicion of SBP, we have to add a third generation cephalosporin like ceftriaxone or cefotaxime. 2 gram IV TAD is a dose cefotaxime, ceftriaxone 2 gram IV BD, or if the patient is sick or with high grade sepsis, we can go for piperacillin tazobactam 4.5 gram TID. So these are the routine antibiotics we can use in SBP. To prevent SBP, norfloxacin prophylaxis. In a patient who is admitted with chronic liver disease, to prevent SBP, we can give rifaximin. They are gut sterilizers. Then if the patient is admitted with SBP, then we have to start ceftriaxone or cefotaxime, because most of the time these SBP is produced by gram-negative organism, E. coli. So these drugs are very important. Third generation cephalosporins are very important. Now when we get a patient who is having skin infection like cellulitis or infection over the foot like diabetic foot and all, most of the time these organisms are gram positive. In an acute infection, most of the time the organism is gram positive like streptococci or staphylococci. If it is chronic infection, then again gram negative organism can come into picture, and anaerobes also can develop there. But in acute infections, we have to suspect streptococcus and staphylococcus, and we have to cover staphylococcus. That is very important. When we are covering staphylococcus, that automatically covers streptococcus. But if we are giving a drug only for streptococcus, that may not cover staphylococcus. So normally when we are getting skin infections like cellulitis and all, we start flucloxacillin. That is a drug available in our country. Flucloxacillin. 1 gram QID is the dose. 1 gram IV QID is the dose. So that can be started. Cefazolin is another drug which also can be used, but commonly available drug is flucloxacillin 1 gram IV QID. That will cover MSSA, that is methicillin sensitive staphylococci. That will not cover MRSA. MRSA is resistant to methicillin, so it is resistant to flucloxacillin or cloxacillin. So we have to go for additional drugs like vancomycin, linezolid, tigecycline, daptomycin and all. So normally if there is a skin infection, linezolid will be a good choice. But remember, when we are starting linezolid, look for platelet count that can produce some amount of thrombocytopenia. So if a patient is already having thrombocytopenia, you have to go for alternative drugs. So linezolid is a good choice in staphylococcus infection if it is due to MRSA. We don't know whether it is MSSA or MRSA, even then linezolid can be started. If you are sure that it is only MSSA, if you have culture report, or if it is an acute infection, we are not suspecting MRSA. When the patient is going for multiple hospitals or multiple admissions histories are there, then we have to always think about MRSA. Otherwise, we can suspect MSSA in soft tissue infection and we can start flucloxacillin. Otherwise, go for linezolid in MRSA suspicion. Now, whenever there is a severe skin infection, always add clindamycin, because these patients can go to toxic shock syndrome because of toxicity produced from the infection. So to stabilize these toxins, clindamycin will be a good choice. So always go for clindamycin along with flucloxacillin or MRSA treatment. Clindamycin dose is 300 to 450 milligram every 6 to 8 hours. Now, other important type of skin infections are diabetic foot. Diabetic foot also we have to suspect organism like gram-positive cocci, but chronic diabetic foot, it will become resistant organism or gram-negative organism. So we have to go for higher antibiotics in this type of conditions. So piperacillin tazobactam will be an ideal choice in this type of patients. So piperacillin tazobactam or clindamycin with ciprofloxacin, all these things are good choice. So remember, in an acute skin infection, it will be mostly gram positive. In a chronic infection, it can be gram positive or it can be gram negative, or anaerobic infections also possible. So flucloxacillin or linezolid alone will not be enough. We have to go for an antibiotic which can also cover gram negative infection like pseudomonas. So we can go for piperacillin tazobactam plus linezolid plus clindamycin. That will be ideal choice in severe infections. Now, another common infection in emergency room is urinary tract infections. We know that urinary tract infection 90% of the time it will be gram negative organism like E. coli. So you can give most of the urinary tract infections we can treat with norfloxacin 400 milligram BD for 5 to 7 days. If it is a female patient, 5 to 7 days will be enough. If it is a male patient, you need to give little more. You may have to give 14 to 15 days. If the patient is having complicated UTI, that is a structural deformity is producing urinary tract infection or uncontrolled diabetes, then also we will have to give more than 2 weeks. So in patients who is having structural diseases, chronic diabetes, uncontrolled diabetes, immunocompromised status, male UTIs also we have to give for 14 days. In female, simple cystitis or urinary tract infection, 7 days will be enough. Ideal drug is norfloxacin. If the patient is having more infections, we can go for ofloxacin. Ofloxacin 400 mg OD is available, or 200 mg BD also can be given. Trimethoprim combinations also can be given, that is Septran and DS can be given BD 7 days. Another important drug is oral fosfomycin sachet. they can be given 3 gram as a single dose in simple UTI, but in complicated UTI or chronic UTI or sick patients, we can give fosomycin every alternate days. But they are very costly drugs. Pyelonephritis, we can go for higher antibiotics or a combination of antibiotic like ceftriaxone with gentamicin or fluoroquinolones IV or ceftriaxone alone can be started. So pyelonephritis, if the patient is sick, we have to give IV antibiotics. So there norfloxacin alone will not be sufficient. We have to give ceftriaxone, that is a third generation cephalosporin with aminoglycoside. In pregnant ladies, avoid fluoroquinolones. We can even go for drugs like amoxicillin, clavulanic acid in pregnant ladies. Cefixime is a good choice. That's a third generation cephalosporin. 200 milligram BD can be given. Most of the patients who are not tolerating drugs like quinolones or who cannot be given quinolones because of seizure potential, pregnancy, and all, cefixime is a good choice. Now, another important condition which can come to emergency room is meningitis, infection of meninges. Whenever we are seeing a meningitis case, we have to always take proper history. MRI may be required, LP may be required in this type of patients. Before starting antibiotic, we have to give dexamethasone. So after giving dexamethasone, we can start the antibiotic. The commonly used antibiotic in empirical therapies, we have to cover both gram-positive and gram-negative organism when we are starting empirical therapy. So we can give penicillin with ceftriaxone. Penicillin mostly covers gram-positive organism which can produce meningitis. Ceftriaxone covers gram-negative organism also. The dose of ceftriaxone will be higher. 2 gram IV BD or TID may be required. Recent guidelines say vancomycin can be given along with ceftriaxone. Vancomycin with ceftriaxone instead of penicillin with ceftriaxone. Vancomycin with ceftriaxone can be given. If the patient is having extremes of age like very young child or very elderly individual, we have to suspect listeria and we can add ampicillin. Ampicillin 2 gram IV TID or QID can be started in this type of patients. So in a patient who is having meningitis, we have to give dexamethasone. After half an hour we can start antibiotic. We have to give gram positive coverage and gram negative coverage. Penicillin or vancomycin with ceftriaxone will be a good choice. If the patient is having extremes of age like young child, very young child or elderly individual, add ampicillin. So 2 gram IV QID can be started. If the patient is very sick, meropenem can be started. Meropenem dose is 2 gram IV TID. Routine dose is 1 gram IV TID. In meningitis, the dose is very high, 2 gram IV TID. So these are empirical therapies. After getting proper culture report, we can de-escalate or escalate the antibiotics. Now, febrile neutropenia is another condition where the patient will have high degree fever and they already have neutropenia due to various reasons. It can be due to an infection or it can be due to malignancy or it can be due to a drug started for malignancy and bone marrow suppression. So patient can have very low neutrophil count and infections. In this type of patients, we have to cover pseudomonas. That is very important. Anti-pseudomonal drug like piperacillin tazobactam. But whenever we have a suspected pseudomonas infection or a confirmed pseudomonas infection, always try to give dual protection. Give piperacillin tazobactam with a fluoroquinolones with any aminoglycoside can be started. So whenever patient is having febrile neutropenia, we have to cover pseudomonas. So patient can have so many different infection, but always try to cover pseudomonas in this type of patients. If the patient is very sick, piperacillin tazobactam with a quinolones or aminoglycoside will be the choice of antibiotic.